at this coordinate at any time.
Oh, thank you. Hey, everyone. Welcome to Measuring Fall and Fall-Related Injury Rates and Prevention Practices. My name is Neily. I work for the Veterans Health Administration and their National Center for Patient Safety, and I'm delighted to be talking to you today about this really important topic. Thank you for joining this webinar, and what we're going to talk about today is measuring fall and fall-related injury rates, and also how do you relate that to prevention practices. A little bit about myself. I've worked for the VA since 1984. Well, I've been a nurse since 1984, and I worked for the VA all of that time except for 1 year where I worked at hospice and palliative care in home health care. I came back to the VA after that and started working in patient safety. And during this time, I've done numerous breakthrough series with teams on how to prevent falls and fall-related injuries and other topics as well. So what I'll do today is bring to you examples of the work that I've done with teams and with participation in fall prevention myself. So talk about today. We're going to talk about the purpose of measurement, because the only reason to measure is so that we can help improve care for patients. So we'll talk about how we can link our measurement to improvement. We'll talk about types of falls and what types of falls to focus on. Some are preventable and some are not. We'll talk about measuring fall and fall-related injury rates, and then how do we measure the practices? Are we implementing the changes that will result in improvement? These topics were introduced in your one-day training, and today we're going to go into a little more depth with them. And please make a note of your questions, and your quality improvement specialist will help you address those after the webinar. Of measurement. Measuring fall and fall-related injury rates can tell you if there are any areas of care that need to be improved, can help you know if the changes you're making are helping you to meet your aims. Are it an improvement, or have we implemented changes that are resulting in unintended consequences and causing problems with other areas? And they can also tell you if you're sustaining your improvement. So it's one thing, and it's hard enough to implement change initially, but it's really important to look at, are we maintaining the gains? Talk about types of falls. This can help us to focus our energy and efforts in particular areas. And this is based on the work of Janice Morse, which you have a reference for that. And so in this work, we looked at accidental falls. Now, these are falls that are caused by environmental factors. Perhaps a patient slipped on the floor. Maybe there was some clutter. We had one site that had long telephone cords, and patients were tripping over those. Another shared they had long bedspreads. These are accidental falls, usually caused by something in the environment, or it could be a simple error in judgment, just not paying attention. The patient's not at risk to fall. In this situation may not be at risk to fall, but they just trip over something. So this is an accidental fall. This doesn't mean, we had some folks who were saying, well, no, every fall is accidental. You didn't mean for it to happen. So specifically, we're talking about accidental or environmentally related falls. And with these, what we want to do, one of the first actions is to determine preventability. Was that fall preventable? Is there something that we could have done to perhaps have prevented that fall, and what action can we take to prevent the next fall of a similar type? Fall are the anticipated physiological falls. Luckily, these are a large proportion of the falls that you're seeing. These are caused by known risk factors as indicated on the Morse fall scale. And what we want to do is look at which of those risk factors are modifiable and make changes related to those. So perhaps a risk factor is loss of balance, and can we work on the patient's gait, their strengthening, their mobility? Maybe they have impaired cognition or confusion. Can we treat that if they have delirium or other problems like that? Impaired vision might be a contributing factor. Do they already have a history of falls? What was happening in those falls, and what can we do differently going forward? So they also have decreased mobility. These are a few of examples, not an all-inclusive list, but of risk factors that can put the patient at a greater chance of falling, and then we can look at what's modifiable about that. Perhaps they're elderly. We can't change their age, but we can work with them in terms of gait, strengthening, balance, modifying medications, treating postural hypotension, and other risk such as these. Again, with this, we wanted to determine preventability. Sometimes we have done everything we can do. We've looked at all the risk factors. We've done all of our patient teaching. The patient understands they should ask for help, but for whatever reason, perhaps due to their strong independent streak, perhaps, they may not ask for help. If you've done all you can do, it's likely that fall was not preventable. On the other hand, if perhaps there is something we could have done that we might have missed or not addressed in a timely manner, then that fall would be considered preventable, and we want to look at what is that action that we can take to prevent the next fall. Third type of fall are the unanticipated physiological falls. These types of falls are not preventable. So these are caused by risk factors that you didn't know about. Perhaps the patient had unexpected orthostasis, extreme hypoglycemia that of which we're unaware, they had a stroke, heart attack, or a seizure. So if you have something like this and you have an unanticipated physiological fall, there is nothing you could have done to prevent that fall. So this gives us a chance to focus our efforts on the preventable falls that we identified from the anticipated physiological and the accidental or environmentally related falls. We want to do this because we only have so much energy and so much time, and we want to focus our efforts on the areas where we can make an impact. So with the preventable falls, an example might be, let's say with the anticipated physiological falls, some people found that a lot of the preventable falls related to toileting. There are many challenges with dignity and privacy with toileting issues. The patient needs assistance but doesn't want to be assisted, so issues like that. So that gives you a trend on which you can focus to say, how can we make it easier to keep the patient safe while they're being toileted and do this in a respectful manner. You want to implement interventions related to that trend and examine any repeat falls that may be occurring. So what do we do with these rates, measuring fall and fall-related injury rates? We want to look at what do we count. Some people say, well, why don't I just count falls, and why do I need a rate? So we'll get to that. What are some of the measures that were used? How do we do this? How do we calculate them? How often? And what kind of data do we need? So the first thing we want to do is count the total number of falls on your unit. And with this, it's important to agree upon a definition of a fall. And especially if you're comparing unit to unit or facility to facility, because we all want to have the same definition. We really encourage within the VA people to fall if debating, is this a fall or not a fall, leaning towards including it rather than not. This isn't so much about counting as it is about finding out what we can do to prevent patients from being injured. So if we do consider something a fall, that will kick into action a series of events to look at how do we prevent the next event of that type. This also gives us a chance to look at the number of repeat falls. If a patient falls once, we want to examine what happened, why it happened, and what we can do to prevent it from happening again. If the patient falls a second or a third time and we didn't make any changes between that first and second fall, then that's really an area where we could put our efforts. We want to look at the level of injury or the number of injuries related to that fall. Sometimes a patient might fall and have multiple bruises or areas over their body in which they're hurt, but they may not have broken a bone or anything like that. Or on the reverse, they might have a severe injury such as a hip fracture or a subdural hematoma. So we really want to look at what was the level of injury for each fall. Now, why do we want to do this as a rate? And this gives us a chance, perhaps the number of occupied bed days went up over a given period of time. So you may have more patients on your unit, which might be why you have more falls. So this is one of the reasons why we always want to look at our numbers as rates so that we can get a sense of our population and how that might be changing. The suggested approach. We commonly suggest looking at the total number of falls per 1,000 occupied bed days and total number of injurious falls per 1,000 occupied bed days. Now, if you, some people say, well, can't I do my injuries out of falls, that's certainly something that's possible to do, but again, if your falls go down, then it might look like your injuries are going up when really what you've done is prevented falls. So we recommend and suggest using occupied bed days as the denominator to equalize that for you. But the most important thing is to be consistent with however you measure your fall and fall-related injury rates. And you can look at section 5.1.7 of the toolkit to look at the national database of the national quality indicators for some more information on how this could be done. And we list a page number there, which it may or may not be exactly that same page when you go to the toolkit, but we want you to know this resource exists. So data do we need? You probably have a good idea of that already from the previous discussion, but for each fall you want to dig a little bit deeper and have an incident report that details the fact that it's a fall, who the patient was, where he fell, and when they fell. Knowing who the patient was gives us a chance to look at whether it's a repeat fall. Where they fell gives us a chance to look at, is the environment an issue with this? Are your falls always happening between the bed and the bathroom? And if so, maybe we could use some night lights or handrails on that path, for example. When the patient fell, sometimes people find trends that more patients are falling during the day when they're getting up and moving. Sometimes people find more patients are falling in the evening or night when there's less staff. It really will vary according to your units. You also want to look at the unit where the patient was assigned. And again, always remembering to do that with the denominator of bed days of care. You may find certain units have a higher risk population than others. Then what are the circumstances of the fall? And looking at that in detail. And then the injury related to the fall. And again, we have another tool, 5A, and that's information to include in incident reports. And this is a great way to really look at what information do we capture so that we can make changes in our program going forward. You'll occupied bed days or bed days of care on your unit. Most of your hospital has this computed already, but if it doesn't, choose the time of day, and at that time of day, check the number of occupied beds on your unit and write down that number. And then you can calculate the fall and related injury rates. You can do it once a month if possible. That's commonly what people do. Some people then like to look at it over a quarter, but the more data you have and the more frequently you look at it, the more opportunity you have to view any trends to really keep that together. And again, another toolkit section is 5.1.6 to really refer to that toolkit to use it to your best ability. What does this look like? Let's give an example. So let's look at the fall rate for the month of April. So you'd look at the total number of falls on your unit, then the total number of occupied bed days, and then you would add up the total number of occupied bed days on your unit, and then you would divide the total number of falls by the total number of occupied bed days on your unit in April, and you multiply it by 1,000 so that you'd have a number that makes sense, that's patient focused. In a similar way, we could do this with the injury rates, and this is what it would look like. 3 divided by 1,809, and then you get your 0.0034, then you multiply it by 1,000. So what does this mean? It means 3.4 falls per 1,000 occupied bed days. And you can see how if the bed days changes, that will affect the rate. But this gives us a chance to say, what is our rate of falls rather than just the number of falls? How do we improve data for fall and fall-related injury rates? You'd want to review the completed incident reports with staff each month. Now, you could also do that as soon as the fall occurs to talk with people while it's fresh in their mind. The benefit of doing it once a month is you can look at any trends in the root causes. Some teams have shared they found trends with wheelchairs being broken. If they repaired the wheelchairs, they were less likely to have wheelchair-related falls. You can trends in fall rates such as falls related to toileting needs, falls to risk factors, perhaps medications, blood pressure medications being prescribed at a rate that causes postural hypotension, gait disturbances, or maybe there are environmental factors. More than once, people have shared that prior to an inspection by outside agencies, people have made an extra effort to make the floor shiny and buff it up, and then the floors were too slippery. So an example of unintended consequences. So that gives you a chance to look at that. So we have all these data. The real goal is to use this information to go forward and implement practices to prevent future falls and fall-related injuries. And a great way to start doing this is to use post-fall huddles or post-fall assessments, and some people also refer to these as after-action reviews. Another tool would be intentional rounding, and this is where we would go and on a regular basis, whatever time frame makes sense for that patient or that patient population, and checking to see if anything that they need. And then incorporating all of the patient's modifiable fall risk factors into their individual care plan. So tool 5B, assessing fall prevention care processes, can also be helpful to you. So not only do we want to implement these actions, but we want to assess whether or not we're actually doing them. So looking at fall and fall-related injury rates tells us the patient outcome, tells us if our patients are better off because of our program. If we find that that's not changing as rapidly as we like or going in the right direction, we may want to dig deeper and look at these specific actions to see, are we actually implementing them? A post-fall assessment huddle and determine if that is being implemented on a regular basis. So a clinical review, we could look at the data after a patient falls. Did the patient have any injuries or immediate problems? And then this might be a new fall risk factor. You might want to review medications or look lab tests. And so that is part of the post-fall huddle, looking at what was different this time that made the patient fall and how can we change that going forward. The clinical review would also include signs and symptoms of fracture or possible spine injury before moving the patient. Of course, we want to use safe handling methods for patients with signs or symptoms of fracture or possible spine injury. So just reiterating, we want to keep the patient safe and we want to keep ourselves as caregivers safe. If the patient has a suspected or possible head injury, of course, we're going to do neurological checks and then have the patient examined medically. Root analysis. This helps us to understand why a patient fell. And with this, we really encourage people to ask why 5 times. And this is another reason why we ask people to do the post-huddle in an interdisciplinary manner. So they have some groupthink. We have some additional ideas. So we have different disciplines. A physical therapist will see something different than a nurse might see, than an environmental specialist might see. So we need to get together very briefly, ideally within 15 minutes after the fall, and talk about what happened, why did it happen, and what we can do to prevent it going forward. Barriers or obstacles to doing post-fall huddles. Sometimes people have competing commitments. They feel like this is adding one more thing to their day. It would be hard to get the team together. Some teams in the Breakthrough series that we've done have done an overhead page to get the team together. And remembering, this is just a very quick huddle. It's not a big, long, drawn-out meeting, but it's, we want to get people together to really talk about, how do we prevent this going forward. Luckily, when a patient falls, people are having some sort of discussion anyway. Wow, I didn't expect that to happen. I didn't think he was going to die. So let's take that conversation and add a few more elements to make it as productive as possible to prevent future falls. Sometimes the fact that the fall was unwitnessed might be seen as an obstacle or a barrier, but we know that a high percentage of falls are unwitnessed anyway, so we need to go ahead and see what we can do and what we can learn. We can ask the patient what, if possible, we can ask the patient what he or she thinks that have contributed to the fall. And there's also multiple causes of falls many times, so that might be a challenge there. And we already talked a little bit about some challenges with assembling relevant team members, but even getting 2 or 3 people together to have different ideas can be beneficial. That might help you with the post-fall huddles. Having a standard protocol so that each time you do it, you don't have to rethink how we're going to do it, so people know how they're going to go through the questions. Some people use a cognitive aid like a laminated card or a little check sheet to remind them of what questions to ask. Another strategy to include might be ensuring the data collected is along with a process you already have in place. So you know you're going to assess the patient after the fall. You know you're going to collect data for an incident report. So any way that you can coordinate and incorporate all of these efforts together would make it easier for people to do. Some people like to have a pharmacist join the rounds to discuss medications that might have contributed to the fall. If this doesn't work for you or may not work every time, one thing you could do is make a consult to the pharmacist to take a look at the medications to see, are there any medications we can eliminate? Are there any that we can reduce the dose or even the timing of the medication? Sometimes a risk-benefit analysis is done, such as with the risk of stroke for the patient being on an anticoagulant with the risk of injury from falls. And it's going to be different for every patient how we determine that balance. Document this. You could do it in the care plan. And what I mean by documenting, this would be the changes that you're going to make going forward. In the VA, we recommend keeping the post-fall huddle out of the medical record so that you can have a protected document that is only internal to the caregiver, so you can feel free to say what you would have done differently going forward. You also want to document an incident report and a risk factor profile. So what would you want to do? You'd want to communicate going forward, okay, the patient fell, and from post-fall huddle, we learned that this is what we're going to do differently. We're going to make sure the wheelchair is at his bedside. We're going to make sure a night light is on, whatever the changes might be. Include those changes in the safety huddle you may hold on your units. So we suggest that you see Section 5.1.6 of the toolkit for an example of a post-fall huddle. So let's say you want to develop a tool for yourself. So how do we measure fall prevention in other ways? We can do medical record reviews. The upside of that is that sometimes you can get rich information about the story of the patient. You really step back and see the trajectory of the care. The challenges, as we know, sometimes everybody doesn't write down everything that they do, so it might be incomplete. So that's why getting information from the staff and the caregivers is really helpful, so you can survey staff, or you can even do direct observations of staff. Sometimes people also like to do safety rounds to know where is a list of patients that are at risk to fall or have fall-related injuries, and you can just go out and do direct observations of what interventions are in place at that time. The combination of medical record review and direct observation. And if you do medical record review, start with manageable samples, such as no more than 2 patients. The other benefit of direct observation is that if you see that an intervention that should be in place is not in place, then you can go ahead and take action, because this isn't research, this is quality improvement, so you always want to do whatever you can to make the patient safer. So, just a few reminders: assess fall and fall-related injury risk each time a new patient is admitted. We've definitely heard stories of patients being admitted, not having a thorough assessment for fall risk or fall-related injury risk. Perhaps they had a fall at home that they didn't mention, and then the patient falls soon after admission. Or perhaps they use a walker at home, but they forgot to bring it with them. So an assessment of the patient's fall risk upon admission is really important. Also making sure that it's an individualized care plan. Does the patient need to get out of bed on a particular side because that's what's best for him and safest? And then the individual patient-specific plans should help reduce the incidence of falls at your hospital and improve the quality of care. So what about today? We talked about the purpose of of measurement, which is always to look at how can we improve care. We talked about types of falls, the anticipated physiological fall, the unanticipated physiological fall, the accidental or environmental fall. And we did that because we wanted to look at what types of falls to focus on. We put our energy on the falls that we consider preventable. We talked about measuring fall and fall-related injury rates and some fall prevention practices. So much for being great listeners, and imagine you have questions and you can direct these to your QI specialist, or perhaps you want to discuss how you're currently implementing some of these practices and how you might do that going forward. A list of resources for you. I hope you'll find these helpful, and remember, you don't have to invent these tools on your own. Your colleagues in healthcare have already been using many of these, and you see the list here, and of course the great toolkit and all of the tools that are available in that for you. So I hope this was helpful to you, and thank you very much.